by Tanya at Fuselight, and in just a minute, we'll highlight her image for you to see. You'll see her drawings in real time as she captures our deliberations and images. We'll end today's meeting by naming our next student and young professional ambassador for the network and learn how we can help to secure Canada's endorsement of the Kigali Declaration. While today's event will be held in English, we are able to answer questions in either French or English, so please feel free to pose your question in the language that you're most comfortable with. Bien que l'événement d'aujourd'hui se déroule en anglais, nous sommes capables de répondre aux questions en français ou en anglais. Alors, n'hésitez pas à poser votre question dans la langue avec laquelle vous êtes le plus à l'aise. So finally, a housekeeping note. We're all pretty used to Zoom meetings by now, but just a few reminders. Please do keep yourself muted if you're not speaking. If you would like to speak, there's a raised hand function at the bottom of your screen and the moderator will acknowledge you. We'd love to see your face. So if your connection allows, please do turn your cameras on so we can encourage engagement today. And please note, as you just saw, we are recording today's meeting. So before we get started, we're going to give you a chance to meet the people in the room today. So pre-pandemic, we would have had a chance to meet over coffee or maybe a drink during an evening reception. But while we can't do that today, we'd like to give you a chance to greet some of your fellow attendees. So we're going to divide everybody into really small breakout rooms and give you a chance to introduce yourself. They're going to be small, but we're only giving you 3 minutes. So you're going to need to quickly introduce yourself, turn your camera on, and meet the other people, some of the other people that are joining our meeting today. Please remember to keep it short so everyone has a chance to introduce themselves. And after that, we'll bring you back into the plenary room to hear more about the Canadian network. So remember that when you leave, to return to the meeting, not to leave the whole meeting. All right, we'll see you in just a moment. So please greet your fellow attendees. You should all be giving a chance to go into a room at this point. And then they'll be coming back into this main room. So we'll give everybody just a moment more to finish up and say hello. So we'll just give everybody a second to say hello, and then we'll come back here. So a different way to start the meeting for those of you who are still here, to allow people a chance to come back. So we'll close the rooms out and bring everybody back. Hopefully they had a chance to greet one another and say hello. So we'll close all the rooms. You've got about 60 seconds for those of you who are still in a room. And we welcome you back to the main session. Hopefully you got to meet some new people. For those of you who got stuck in the, maybe you met people you already knew before, but hopefully you had a chance to say good morning and meet some new individuals that you haven't met before. So we'll pass over to Tina, who's going to tell you a little bit more about the Canadian Network for NTDs.
Hello, good morning, everyone. I am the Advocacy and Policy Officer at the Canadian Network for Neglected Tropical Diseases. It's been an honor to work with such a small but mighty network this year with ambitious goals for Canadian commitments and contributions to ending NTDs globally. The work of the network is guided by a dedicated steering committee, many of whom are here today. I'm wondering if we can put this, we can have gallery mode, and maybe we can have all of the steering committee members turn on their cameras and wave. If you also have your camera on, please keep it on as well. It would be nice to just have a little wave. Thank you. And we're going to play now a short video introducing the network, combined with our networking video of people working and learning in the NTD space.
Great, thank you, Tina, for giving us a brief overview of the Canadian Network for NTDs. We hope that after today's event, some of you will want to become members of the network. You can see it's a vibrant group of individuals from across Canada and outside of Canada. So I'd like to set the stage for our event today, which we've called Exploring the Nexus of Poverty, Equity, and NTDs. As you'll hear in today's presentations, 1.7 billion people live at risk for neglected tropical diseases, or NTDs. That's more than 1 in 5 people living in the world today. You may ask yourself, well, why haven't I heard more about these diseases? You probably have. Some of the 20 named NTDs include leprosy, elephantiasis, dengue fever, snake bite, sleeping sickness, rabies, and river blindness. These are ancient diseases that affect people living in already vulnerable circumstances, perpetuating the cycle of poverty for affected households. You see, if one member of a household is disabled by chronic NTD infection, the effects spread to the rest of that household. Children may need to stay home from school to care for the affected person and help with household chores. Less income will come into the home. Stigma will affect the individual's ability to socially interact in his or her village or community. Marital prospects may reduce and mental health may suffer. Some have said that it is not the diseases that are neglected, but the populations that are. So if we want to get serious about ending poverty and achieving global health equity by 2030, we have to start thinking about addressing neglected tropical diseases. At the Canadian Network for NTDs, we have said that NTDs are the missing piece in global health. Canada has made tremendous global health investments through its Muskoka and recent Thrive initiatives. Many of you in the room have worked on these ambitious targets. Yet COVID-19 has taught us that a single issue approach isn't always the most effective way to reach our global health goals. Rather, we need to find those points of intersection where tackling one issue may positively impact others. For example, provision of water and sanitation and good veterinary care can improve many health outcomes and reduce the risk of infection with NTDs. Deworming as part of school health can improve educational achievements for children and adolescents, paving the way for future opportunities for boys and girls. And including NTDs as part of a sexual and reproductive health initiative can reduce infertility and even the risk of HIV infection. Today, we'll present some examples of the intersections of poverty, equity, and NTDs, and show how NTDs need to be part of our global health goals. Finally, why should we care about NTDs in the midst of a global pandemic? As our resources and efforts have been diverted to address COVID-19, we've learned that addressing public health shouldn't be a zero-sum game. We've experienced losses to decades worth of health gains because of diverted human and financial resources and the disruption of services. The global efforts to eliminate, control, and eradicate NTDs have not been immune to these losses. Prior to the pandemic in 2019, we celebrated the 5th consecutive year where over 1 billion people were treated for one of the 5 NTDs. However, unfortunately, due to the pandemic, a recent WHO survey found that 44% of countries experienced disruption to their NTD interventions, including the distribution of preventive treatments, as well as services that care and manage disability. NTD disruptions are only second to disrupted services targeting mental, neurological, and substance abuse disorders. The public health consequences are expected to increase the burden of mortality or morbidity due to NTDs. We know that NTDs affect people at the end of the road, people who may already be left behind in terms of economics, education, security, and health. So if we're serious about reversing the additional losses due to COVID-19 and achieving global health equity, we need to ensure that we stop neglecting those people who live at risk for NTDs. So in closing, I have 3 hopes for you today. One is that you'll learn something new about NTDs, about Canadian engagement in NTDs, about what you can do. Second, I hope you'll get engaged with the Canadian Network for NTDs. And third, that you'll help us to raise awareness here in Canada about the importance of Canadian contributions to global health to ensure a world free of NTDs. And now it is my great pleasure to introduce the Honorable Mohammed Iqbal Ravalia, who is Senator for Newfoundland and Labrador, and who will share a few remarks to open our event today. Senator Ravalia is a respected physician and medical educator who was appointed to the Senate on June 1st, 2018. He's received a number of awards, including the Order of Canada, the Queen Elizabeth II Diamond Jubilee Medal, Canadian Family Physician of the Year, as well as Community Teaching Awards. Thank you, Senator Ravalia, for joining us today and for welcoming everyone to the meeting.
Thank you very much indeed, Alison, and a good morning to everyone online. I'd like to begin by thanking Alison and her team for setting up this very important meeting. And my gratitude also goes out to Sarah Pollowin, who is a member of my parliamentary staff. I'd like to express a very warm welcome to all participants and a special hello to those of you who are signing on from outside of Canada. Congratulations to all members of the network. Your untiring efforts have brought to the forefront an awareness of the tragedy that faces individuals with NTDs and the importance of us coming together jointly in responding to their needs. My colleagues in the Senate, Senator Peter Beam, Senator Stan Kuchar, and I were fortunate enough to partake in an international global parliamentary meeting with respect to NTDs and our response to them. And we're delighted to announce that Senator Stan Kuchar will be representing us on that executive. In the work that I've done thus far internationally, there is a disproportionate emphasis, unfortunately, on HIV, AIDS, and TB, and their eradication is particularly important. But it's very, very important that our advocacy continues in a strong and forthright manner to ensure that we create an awareness of NTDs and also to put forth a plan that affords a tangible response. As parliamentarians, We will continue to advocate strongly for a path forward in an effort to eradicate these conditions. I think it's important that I mention to you as well that I was born and raised in Zimbabwe, where I did my medical training. And so I am particularly familiar not only with NTDs, but the significant mortality and morbidity that these conditions bring. And it is absolutely heartbreaking to witness the negative impacts, as Alison has alluded to earlier, on not just the individual, but on a family and a society on a whole. And so many of these are preventable by very, very simple measures. For example, a clean water supply or a very, very low cost medication that can be administered. Your participation today is sincerely appreciated, and I look forward to the discussion that'll follow. Thank you very much.
Thank you, Senator Ravalia, and we're just so delighted with the support that you and Senator Kuchar and Senator Beam have brought, and welcome you all in your attendance today. And we look forward to working with you and continuing to raise awareness here in Canada about NTDs. So thank you very much. And now I'd like to hand over to my colleague, Manish Phillip, who is with Affect Hope as the Director of International Programs, and he will be moderating the next part of the session. Thanks, Manish. Over to you.
Thank you, Alison, and welcome everybody. This next segment, we will be together for about an hour, and we are bringing to you 3 informative presentations on different areas of neglected tropical diseases. The first presentation is being brought by Dr. Emily Jenkins and Dr. Momar Endau, who will be presenting on NTDs that not only affect the tropics, but are also present in our own Arctic North. Dr. Emily Jenkins is a professor and veterinarian at the Department of Veterinary Microbiology at the University of Saskatchewan, Canadian representative to the Terrestrial Working Group of the International Arctic Science Committee, and Dr. Momar Endau is Associate Professor, Department of Medicine, Faculty of Medicine and Health Sciences at McGill University. Over to you, Emily and Momar.
Thank you so much. It's a real privilege to attend today. I am going to kick this off. Hopefully you are now seeing a slide that says CNNTD and my name and Momar. Excellent. That's great. So I am a veterinarian, which I always put in my introduction, just so that people understand the limits of One Health. Does not mean I can practice human medicine, but I do work very closely at the interface with human health and animal health and environmental health. So that is the term, the catch-all term that we use for that is One Health, which is that missing piece that can bring together these different concepts of health and these different contributors and drivers of health. The idea behind One Health is that there's really a place for everybody in One Health, and it means different things to different people. And sometimes this term gets a little under crossfire for meaning too many things to too many people. But really fundamentally what it boils down to is we need to take multiple perspectives and multiple approaches to improving health for all. And that health can't simply be an anthropocentric viewpoint. It also needs to look at animal health and environmental health, because all these healths are interconnected. So it's a very inclusive umbrella, and everyone is welcome under the One Health umbrella. It also has particular relevance to neglected tropical diseases. And Alison's already done a fantastic job of identifying what neglected tropical diseases are. But I'm just going to go back to first principles here and say, mostly they're tropical because they mostly happen and affect the Southern Hemisphere. Some of the countries that are the most populous worldwide, and also countries that are least equipped to deal with emerging issues at animal and human health interfaces. Sorry, it's just getting started in the morning here, where I am in Saskatchewan, Canada. So we don't see a lot of these diseases in the Northern Hemisphere, but I am going to tell you about a few that we do see. And I don't want to downplay how important it is to address these problems where they originate, which is in the Southern Hemisphere and in the tropics. But they aren't just a tropical disease problem. And that's one of the challenges, is that when we say something is tropical, sometimes we tune out and think, oh, that's not in my backyard. So the purpose of my and Momar's talk today is to let you know that yes, these are in our backyard. Yes, we do need to care about them. In terms of the word neglected, I think this is really well illustrated by the 4 graphs that you see on the side of your right-hand side of your screen, showing that, for example, the proportionate number of research papers written on diabetes, which is a major problem in the first world, and HIV/AIDS, which is a major problem worldwide, you can see the huge amount of research effort that has gone into those diseases and continues to go into those diseases. In contrast, if you look at the blue writing over here, you can see the proportion of the world affected by these neglected tropical diseases, including up to 1 billion infected with intestinal helminths. And you can see the very paltry amount of research papers that are currently being devoted to studying these very important public health issues. So that's the part of neglected, is that we're not channeling the resources into fighting these diseases that we really should be, proportionate to their impact on public health. So what does One Health have to bring to the table for neglected tropical diseases? The really neglected tropical diseases are One Health. And if you look at this little Venn diagram, you can see there are a bunch of environmentally transmitted diseases in green. There's an orange group here that are zoonoses that involve animal reservoirs, or animals are a direct source of exposure for people. On the right-hand side is vector-borne diseases like dengue fever and onchocerciasis, or river blindness. And then in the middle, we have diseases that are actually transmitted through multiple routes that may be zoonotic and vector-borne. And there's only one disease that's truly human-to-human transmitted of these 20 neglected tropical diseases. So if we're not taking a One Health approach to mitigating these important diseases, we're not going to do a good job of mitigating these important diseases. So today we know that more than 2 billion people are currently affected by neglected tropical diseases, and that their major impact is in the Southern Hemisphere. And you can see on the right-hand side that it's a diverse group of pathogens. It's all over the map, from worms to tapeworms to protozoans, viruses, and bacteria. There's not one particular group that's represented more than another, but they do affect people in the millions. So these are not niche diseases. These are diseases that are affecting day-to-day life all across the planet. The other thing that I want to bring to the table as an Arctic scientist is that it's simple and easy, if you put the word tropical in a title, to ignore the fact that these aren't actually so tropical. And we definitely see them in countries even like Canada. And where we see them is in our most underserved populations, like our remote, Indigenous, and Northern populations. And while I take a little bit of issue with calling these neglected infections of poverty, because many of these diseases are not, should not be linked to socioeconomic stigma, they are in fact linked to things like consuming local wildlife and having close connections with the land. There is no doubt that these kinds of diseases, I've given you 3 different parasites here. One is a roundworm that's transmitted through consumption of meat. One is a protozoan parasite called toxoplasmosis, which most people think of as associated with cats, but is in fact often a food and waterborne disease as well. And finally, a little tapeworm called echinococcus, which I'm going to talk about a bit more specifically. So in terms of how people are exposed to these, it's quite often through food and water. And it is happening in a population that has the least access to healthcare in Canada. So many of these communities aren't served by even a single doctor, and that for even getting a diagnosis, they have to travel outside their community by plane to get the help that they need. So we have a higher incidence of these diseases in these populations that are the least able to access healthcare. So these are, there's a great title, Tropical Problems in the Arctic ? They're not really just tropical problems. Neglected diseases are neglected worldwide. So I wanted to tell you a little bit more about this one particular tapeworm that is the subject of my research, called Echinococcus multilocularis. Dogs and wild canids like coyotes, wolves, and foxes have the parasite in their intestine. They pass eggs out in their feces, which contaminate the environment. And then people, and interestingly as well dogs, when they accidentally ingest these eggs, they can develop a very severe disease called hydatid disease or echinococcosis in their organs. And that can be life-threatening in both dogs and people. So these are some images from real cases that I've been involved with. Here's an ultrasound image on the upper left-hand side here of a dog that has the tapeworm, the larval stage of this tapeworm in its liver. You can see there's no normal liver left in this picture below. It's all affected by this white nodular material, which is the parasite. This parasite also does the same thing in people. So most often starts in the liver, but it can also metastasize almost like a parasitic tumor throughout the rest of the body, and including places like the brain. The other challenge and what makes this a neglected disease is that there is only one drug that is really effective against this disease in dogs and people. And it's very hard to get access to it in Canada. It requires a specific application to Health Canada every single time a patient needs this treatment. And it's a long-term chemotherapy, at least 2 years, if not lifelong, to keep the parasite under control. So that's why it's a neglected disease, and it's right on our doorstep, transmitting in our country. I am now very happy to pass the torch over to Momar, who's going to tell you a little bit about some diseases that originate in the South, but are also on our doorstep.
Hi, my name is Momar, and I don't know if I will be able to use my cursor or not, Emily, do you think?
Sure. Do you want me to stop sharing and you can share?
If you don't mind. Thank you very much. Okay. Can you guys see my screen? Yes?
Yes.
Okay, thank you very much. So what I had to say here, I have something common with the Honorable Senator Muhammad Ravani, who is born and raised in Zimbabwe. So I was born and raised in Senegal, but I have to say that in a really, really, really poor area in a village. So talking about all this negative disease, we have to pick up, and getting one is difficult, but I'm going to talk about today Chaga disease, which is the American trypanosomiasis, because we live in US, in North America. This is a cousin of the sleeping sickness, the human African trypanosomiasis. This disease is spread in the endemic area, Central, South America, and Mexico by this bug you see here, which is called the kissing bug or Ridley bug. There is up to 18 million people are infected with this orphan disease. It's a neglected. Why 50,000 people die every year for Chaga disease? But it's really worry about for developed country. This can be transmitted through the blood transfusion, organ, mother to child, but up to 4 generations. I'm going to show you some example, and also contaminated food, which is really something. But when people are infected, they are not aware. They can live with the disease for up to 30 to 40 years without knowing they are sick, and develop these mega syndrome, megaesophagus, megacolon, and even cardiomyopathy, and they can die. And remember, the fact that this disease can be transferred from the mom to the child. That's why in 2007, at the American Society of Tropical Medicine IGN, which I'm a member since 1998, we said that American trypanosomiasis Chaga disease is no longer an exhaustive disease. The following year, the government of Canada called a meeting in Ottawa. We spent 2 days seeing how we can tackle this disease, because it's a growing public health threat that requires collaboration at home and also abroad. If you see in this map here, the number of migrants with trypanosoma crazy living in non-endemic country, you can appreciate here in USA, in North America, that more than 300,000 people may live with Chagas disease where they don't know their status. You can say, yeah, in Canada it's 2 up to 3,000, but this is the tips of the iceberg. And I can tell, even in collaboration with WHO DNDi, because they have a neat technology that can detect a biomarker to tell when people are infected or not with Chagas disease, if they respond also for the treatment. I have to mention that the treatment is toxic. There's only 2 available drugs that can help these people with chronic infection, and they don't have even access to this toxic drug that people have to take it up to 6 to 90 days with no choice. Chagas is in our doors, not only in the Central or South America, but it is well documented that trypanosome crazy were reported in mammal in southern US. You can see from raccoon, Operation Ringgold, coyote, dogs, and even rodents. So Chagas is in our door. And recently, there is a paper pointed out that research showed the potential that the bed bug can transmit Chagas disease, and this could pose a high risk of infection of people. If you live in Quebec, remember, every July 1st, people tend to move around getting new apartments. So it's not only a disease for the South, but we have them here. Just to give you a quick example, if I wrap it up, this is an example. Long time ago in 1986, this patient with acute lymphoblastic leukemia received platelet, and the implicated donor is from a rural Canadian farming community. But the donor born in rural Paraguay lived there for 10 years and moved to Canada and lived here for several years. He was not aware of his status. He gave the blood. Unfortunately, this patient was infected in 2000, and I was here at that time. This patient with leukemia again received 294 blood component. Most of the time it was platelet. The implicated blood donor also was raised in rural farming, born in Germany, lived in Paraguay, has a child, and gives his blood. So that I said at the beginning, there is a vertical transmission quickly. This is the female, 20 years old, born in 96, asymptomatic, never traveled outside, only North Dakota, Minnesota. Mother and maternal grandmother, born and raised in Canada. Unfortunately, the mother received transfusible in Manitoba. And as you see here, she was positive for Chagas disease, confirmed. Another case also happened not only once, but there is a cluster also that visited our clinic, Tropical Medicine Center at McGill. As you see here, the entire family living here for so long was infected for Chagas disease. We have another case also published here. All we are saying, there was a spotlight at Journal of Montreal. We're saying with the blood screening, Canadian physician are going to see patients with Chagas disease and should know how to manage them. Thank you very much for your attention. Et ça me fera un grand plaisir, si vous en avez des questions, d'aller répondre aussi en français plus tard. Merci.
Thank you, Emily and Momar, for this excellent presentation. I'm just letting everyone know that we will have questions and answer session after all the 3 presentations. So please hold on to your questions, and we will do that in breakout rooms, 3 breakout rooms with a mix of people who are presenting and some of us from the Canadian network. Our next presentation is on adolescent and soil transmissible helminthiasis. And this is being brought to you by Dr. Teresa Gyurkos, Shibani Sharma, and Dr. Marion Roche. Dr. Teresa Gyurkos is a full professor at the Department of Epidemiology, Biostatistics, and Occupational Health, School of Population and Global Health, Faculty of Medicine and Health Sciences at McGill University. This week, she was also appointed to WHO's advisory group on soil transmitted helminthiasis and schistosomiasis control and elimination. Shibani Sharma is a junior technical officer for adolescents and women's health and nutrition program at Nutrition International. And Dr. Marion Roche, who is a senior technical advisor, adolescents and women's health and nutrition at Nutrition International. Over to you, Teresa, Shibani, and Marion.
We don't hear you, Teresa. You need to unmute yourself.
Thank you so much, Manish, for the introduction, and thank you, LaShawn, for advancing the slides. Good morning, everyone. The three of us are here today to talk to you about adolescent health and soil-transmitted helminths. Soil-transmitted helminths are, in fact, the most common of the neglected tropical diseases, and adolescents are one of the most neglected of all the populations that in fact suffer from neglected tropical diseases. And we are shining a spotlight today on adolescents with respect to soil transmitted helminths. And you will see why in a moment. Next slide, please. This is an area in Peru where I have done my research program over many years. And you can see perhaps in this picture, the poverty. And while you can't see the people, they are a very impoverished community living on the banks of the Amazon River. This photo can be taken in over 100 countries in the world, places endemic for soil transmitted helminth infections or intestinal worm infections. Next slide, please. These are the soil transmitted helminths. They're a group of 3 intestinal parasites or worms, roundworms, whipworms, and hookworms. And they are co-endemic. So they are transmitted usually together in over 100 countries of the world. And as Emily and Allison have already mentioned, over 2 billion people on this planet live daily with these worm infections. The DALIs that are lost every year are important, and the NTD roadmap that the World Health Organization has just published aim, together with the Sustainable Development Goals, aim to eliminate as many of these neglected tropical diseases as is possible. And one of them will be the soil transmitted helminth infections. Next slide, please. So this is an age prevalence, this is an age intensity curve for the soil transmitted helminths, and you will see that soil transmitted helminths are acquired early in life. And all the 3 curves also increase over the lifespan of both boys and girls. The school ages between 5 and 14 years of age suffer mostly from, for example, roundworms and whipworms, and in early adolescence, the hookworms have their peak intensity. So what we see for adolescents, who WHO define as children between the ages of 10 and 19 years of age, you see that the peak intensities of these 3 intestinal worm infections are highest in the adolescent groups, being acquired early in life, peaking in the early adolescent groups, and then sustaining their intensity and manifestations over the adult lifespan. Next slide, please. In 2018, a group at WHO published the numbers of girls and women of reproductive age who were impacted by neglected tropical diseases as a whole, but also in terms of soil transmitted helminths. So you will see here the women of reproductive age category, and women of reproductive age who are at risk of these soil transmitted helminth infections number over now 700 million women. And you can see that about 20% of them were treated in 2017. The women of reproductive age category include 4 subgroups, and included in this category are adolescent girls. So we know that about 15 to 20% of women of reproductive age are adolescent girls who are at risk of these intestinal parasites. Next slide, please. So what can deworming do? It's one intervention that we can use to reduce the morbidity caused by soil-transmitted helminths. And the deworming that we're talking about is what we call preventive chemotherapy using single-dose drugs called albendazole or mebendazole. What happens when you give a girl in a developing country endemic for soil-transmitted helminths one of these drugs? And usually it's done on an annual basis. So periodic deworming, we know, and there have been many research projects that have confirmed this, it reduces the cumulative buildup of intestinal worms over time. So if you regularly deworm, for example, students in a school who live in an endemic area, you will reduce the number of worms that they will accumulate over their lifespan. So this is a very important approach that endemic countries now are using to stop the buildup of intestinal worms in the gut over time. Periodic deworming also reduces anemia caused by these worms. So for adolescent girls and for women of reproductive age, especially pregnant women and lactating women, having these worm infections increases their risk of anemia. And so that is why also WHO, other agencies, and countries are now planning implementation and deworming programs targeted to adolescent girls and women of reproductive age, especially the pregnant women. We also know that periodic deworming reduces school absenteeism so that it has an impact in educational performance during the school years. Periodic deworming also best prepares female adolescents for later pregnancy, again, by reducing anemia and by reducing the buildup of these worms over time. Of course, deworming with a single drug once a year is not going to eliminate soil-transmitted helminthiasis. So WHO and PAHO and other UN agencies, including World Food Program, for example, also include other educational interventions. These include education, hand washing, shoe wearing, improved sanitation facilities, and improved waste management. Next slide, please. In Bellagio, we had a meeting where we actually had a declaration which stated that every girl and every woman of reproductive age who is infected with soil-transmitted helminths has the right to be treated. Next slide, please. I will hand over now to Shibani and Marian to continue the presentation.
Thank you so much, Dr. Teresa. Hello, everyone. My name is Shibani and I work with Nutrition International based at Ottawa. Through this slide, I will briefly talk about the document titled FAQs Preventive Chemotherapy for STH Infections Among Adolescents in WRA. So we prepared this document early this year, and Dr. Teresa and Dr. Allison, they have kindly technically reviewed the document. So thank you for your support and inputs. So this FAQ is intended to support and advise on current evidence-based best practices to the questions which are faced by program officers in the field due to knowledge gap and lack of resources on deworming. And to share a little background, so when this WHO 2017 guideline was was released, we shared it with our team, and they requested us, if we can develop an FAQ, which, can help them answering some regular questions they face on the field. So from there, we started developing this document. So what we did is we compiled a list of frequently asked questions, and for that we organized a survey monkey, and we collected these questions from our project officers who are supporting our program in Asia and Africa to support the adolescent nutrition program. So this document includes 28 questions, and we have divided it into 5 sections, and they covers questions related to drug dosage and their effect among adolescents. Then some questions related to policies and guidelines, what are the evidences available on benefits and effects, and a couple of questions on programmatic questions. I have provided the link in the slide, and I'll also paste the link in the chat box. So please feel free to go through it, and we hope you will find it useful. So whenever you have time, please have a look. So yeah, so thank you, and over to you, Marian.
Thanks so much. I'll start by going to the next slide, please. Thanks so much to Teresa and Shibani for highlighting kind of adolescence as being neglected, and how deworming is really part of this, reaching a critical need of adolescents. And we think of reaching adolescents, often we have policies and guidelines, and like Shibani said, we don't necessarily know how to implement them, especially through the health sector. As we know, adolescents are not really accessing the health system, especially not for preventative services. There's often stigma to going. Girls may want to go, but they may be feared of being, someone might suspect they're pregnant, they might suspect they're going for contraceptives or other things that have a lot of stigma with them. So we've often looked at schools as a potential to deliver health services for adolescent girls and boys. And we look at those who are enrolled, as well as maybe we can reach those who are not enrolled through siblings who might be able to bring things home for brothers and sisters, or even neighbors or cousins or things like that. And we've also looked at other public health intervention programs, such as HPV vaccines that may have funding and may already be engaged with the schools, to see if we can join things like nutrition interventions and the deworming programs with those, so that they can get a package of services. We've also been exploring other opportunities, such as social media, for reaching adolescent girls with information. Sometimes, through different chatbots or AI, they're able to ask anonymous questions that they might not feel asking in person. This is increasingly more relevant as more adolescents having access to mobile phones, either their own or being able to borrow one from a family member, especially in the Asia region. And we've looked at other opportunities, such as existing community groups, such as Girl Guides, in some of the countries we work in. And I'll go to the next slide, please. This map here just shows you where Nutrition International is working with adolescents. If you look at the countries in red, those really show our traditional countries where we're looking at, health system strengthening and traditional programs through Ministry of Education, partnered with Ministry of Health to deliver services to girls, and in some cases also through social protection programs and other Ministry of Health community-based clinics or facilities. And the countries that you see in blue, or combinations of blue, red, and yellow, are ones where we're testing new interventions and platforms, such as partnering with Girl Guides, with UNFPA, or also looking at social media and other ways of reaching girls with information. I'll go to the next slide. Thank you. So one of our motivations for looking at nutrition in adolescents is, in 2015, there was a global analysis of what's causing lost quality of life years, or disability adjusted life years, for adolescent girls. And this is really a fancy statistical calculation for looking at what's causing illness and death and disease in adolescent girls. And iron deficiency anemia came out on top for both the 10 to 14-year-old younger adolescents, as well as the 15 to 19-year-old girls. So this was a lot of the motivation for Nutrition International's increased focus on adolescent girls. Next slide. Thank you. So when we look at our program approaches at Nutrition International, we have specific nutrition or nutrition-specific interventions. That's weekly iron folic acid supplementation, and that's designed directly to reduce the anemia. And then we also package that with nutrition education, and that teaches girls and boys about their health, their puberty, their growth, their needs, their benefits from physical activity, as well as diet. We also look at nutrition-sensitive interventions, which might not be perceived as your classic nutrition interventions, such as keeping girls in school is one of the best long-term things for their health and nutrition. Deworming and wash, Teresa has shown us how deworming is critical for keeping, school attendance, keeping children in the class, but also for their academic outcomes. And, our nutrition education also includes wash, water and sanitation and hygiene. All of that is, relevant to overall health, as well as food preparation and management as well. And we've given a special focus on menstrual hygiene management. And this really helps to overcome a gender barrier. Many girls may not attend school for certain days of the month with stigma around menstruation. So we want girls in the class and we want them there as many days of the month as possible. Along with this, we've also looked at other gender barriers, such as early marriage and adolescent pregnancy. Once a girl is married or pregnant, she's very unlikely to stay in school. And once she leaves, she's very unlikely to return. And this can set up, risks for poverty and lost opportunities going forward. So we really see working with adolescent health and nutrition as being, overcoming gender barriers. Girls have increased nutritional needs that can impact their school performance if they're not met. And that can really relate to gender inequalities. So at the center of our programs, we really want to see healthy adolescent girls. Next slide, please. When we reflect on the last, year and a half and the implications of COVID-19 on adolescent nutrition, it really started with, a decreased focus on adolescent nutrition. And this would be the same, for neglected tropical diseases and adolescents as well. So a neglected group being further neglected. There were supply chain interruptions for, iron folic acid supplements, deworming supplements and products as well. That meant, delivery was not necessarily a priority and not possible in many cases. There was increased food security, especially true for children who relied on a school meal for part of their diet, with school closures in all of the countries where we were working. And this also meant a decrease in coverage in weekly iron folic acid supplements, as well as in deworming. In some cases, children missed 3 rounds of deworming. And in many of our programs, we went from a coverage of over 5 million girls getting WEFAs in 2019 down to 200,000 getting any of the supplements in the following years. This means increased risk of anemia, as well as soil transmitted ailments. And then also we see dropouts, and this is something that may not get better right away. Some of the children that left school are not returning now that schools are reopening. And some of this is from early marriage, pregnancy, gender-based violence, and adolescents needing to take on low-paying and high-risk jobs to support their families. So we see a lot of gender inequities that have been perpetuated by COVID-19. Next slide, please. When we reflect on the lessons learned from our programs from 5 years prior to COVID and then the last couple of years with COVID, we really realized that adolescent nutrition and policy strategy is critical. We need these policies and guidelines, and the deworming guidelines are part of that, as well as the weekly iron folic acid guidelines, but we also need to support countries to be able to implement them. And in many cases for adolescents, this means going beyond the health system, as we know adolescents may not be accessing the services. And the school delivery platform has really been the most cost effective, but we really need to reflect on that as well in the time of COVID, what it means when that platform, shuts down. How do we continue to reach adolescents and be more flexible? We also have appreciated that adolescents really need age context information. There's a huge difference between a 10-year-old who's still very reliant on parents for information and support and has high trust in her parents versus an 18 or 19-year-old who's starting to transition away and gain more independence, relying on her peers. And we have found that peer adolescent girl leaders can be, a key source of helping to design programs, providing information, and being leaders. And they're often already mobilized at many schools with other activities or school committees. So we've been working with them to give them training so they can choose the nutrition issues and health issues that they want to take forward. And some of these have been school-led water sanitation committees, making sure, latrines and facilities really meet a standard and a quality that's acceptable, including locking doors and basic concepts that are important for gender considerations for girls. And when we think of reaching out of school girls, this is really our biggest challenge for programs. It's a hard to reach group. They're often vulnerable for social reasons as well. There's often a reason that they're not in school. So this is an area where we really need to direct more resources going forward. And I think COVID has also highlighted this, that when the schools close, often the adolescents become even more vulnerable and more isolated from services. So I think this is our challenge going forward. As schools reopen, how do we build in those systems to keep reaching girls, even if they end up not being in school in the future? Next slide. So I'll end by just really saying that we see an opportunity in looking at adolescent health and nutrition. We see it as, really investing in their current nutrition, reducing anemia, improving their potential to do well in school. And it's also an investment in their future nutrition and health. Adolescence is such a stage where healthy lifelong hygiene, nutrition, and lifestyle behaviors are starting. And, with diet, exercise, the information, understanding their current health, their future, their growth, this is a key opportunity to give both boys and girls the life skills that can help for a healthy lifelong approach to nutrition. And we really see adolescent nutrition and health being part of promoting gender equality and girls' empowerment. They have a lot of specific nutrition and health needs, and it's important for them to understand those needs and to meet those so they can continue to, thrive and do well in school and have opportunities. And I'll end there, and we look forward to discussing this with everyone after. Thank you.
Teresa, Shibani, Marion, thank you so much for sharing this very important area of work with adolescent girls and boys. And it always amazes me how many people are affected by intestinal worm infections. We will now go into the third presentation, and I'm delighted to introduce you to Guillermo Robote-Aque. He is my colleague at Effect Hope, and he's our technical advisor. And he's been working in this field for a number of years with a special focus on leprosy, lymphatic filariasis, and other related entities. And he will be speaking on NTDs, disability, and mental health. Over to you, Guillermo.
Thank you very much, Manish, for this kind introduction and for the opportunity to present this important topic. So together with these interactions between NTDs, disability, and mental health, I'll try to summarize an example of an intervention we have recently implemented in Bihar state in India, addressing all these topics together. So next slide, please. Okay, so I guess there is a wide recognition within the NTD community that the disabling effects or debilitating effects of NTDs define better the burden of NTDs rather than incidence alone. Of course, there are different degrees of transmission depending on the NTD, but I think there is a wide recognition that it is precisely the disabling and debilitating effects of NTDs that define better the burden of those. So, but what are those disabling effects? What is disability? Because we also understand that disability goes far beyond the physical consequences of associated to NTDs. In this context, the International Classification of Functioning, published by WHO in 2002, states disability is an umbrella term for impairments, activity limitations, and participation restrictions, which is really a call to address the healthcare needs, considering the individual and environmental factors and the interactions of mental health stigma through participation restrictions. Next slide, please. So how these components, how does disability, stigma, and mental health interact each other? Well, this is a model published by Julian Eaton and others back in 2017. I'll try to summarize here. This is an adapted version. So this model really suggests that stigma may trigger a vicious cycle of affecting many aspects of life. So starting with the gray cycle, negative attitudes are often internalized by people affected, potentially leading to damaged self-esteem that, together with participation restrictions, may cause mental health problems. So poor mental health has a direct effect on low treatment compliance and health-seeking behaviors, leading to poor health outcomes and, of course, increased disability, reinforcing discrimination. In addition, discrimination and the different forms of structural stigma may affect, the available resources allocated to manage the chronic conditions throughout the continuum of care, and of course affecting poverty and equity, and then feeding back into the cycle, worsening health outcomes and mental health issues. Next slide, please. So this is basically a study I published with colleagues, with former colleagues a few years ago. And this study was basically a cross-sectional study among people affected by leprosy and lymphatic filariasis in some states in India. And the idea was to assess the association between possible risk factors and mental distress. And we found indeed, in line with what we have just commented, that the main risk factors, we found strong statistical evidence for association between disability, poverty status, and discrimination and mental distress among both, in both LF and leprosy. Of course, there are other risk factors, but I think this frames, in an attempt to operationalize this theory, this helps framing the population at risk and who should we target with mental health interventions. So next slide, please. Okay, so in the literature, it is widely recognized, in order to address mental distress and stigma particularly, the idea, we should all consider in our programs the prevention, the early detection, the follow-up, and the referral of severe cases to specialized healthcare services. And there's a growing evidence on effective mental health interventions, particularly activities that, it goes that in a siloed manner, they are very effective. The problem and the question is how we integrate mental health interventions into our programs. Because at the end of the day, we just seen through the cycle earlier, that mental health has strong interaction with healthcare. So health organizations addressing healthcare needs are only considering part of the equation. So addressing healthcare alone or in a siloed manner without addressing mental distress is only partly effective in the quality of life, in impacting their lives in the long term. So how can we integrate the mental health into effective but also sustainable, scalable, and feasible programmatic model? Next slide. So here's where we start this project. This is an example of an intervention, the UMID project, implemented a couple of years ago, and last year actually, and it stands for Understanding Morbidity Management in Elephantiasis to Enhance the Delivery of Services. This was implemented in Bihar state, one of the most endemic states in India on LF particularly, and it was funded through UKAID, through core NTD, and in close partnership with the Bihar state government and the implementing partnership LEPRA. And the Brugger Research Institute and FED Hope, we played a key role in supporting technically. Next slide. So in India, a plan for the elimination of LF was developed in 2018 with clear objectives. And for those not knowing, not familiar with LF, the main intervention is about providing mass drug administration, or MDA, which is based on providing preventative chemotherapy. But what's new here, what was new, is that they include an objective addressing the improvement of MMDP services, which stands for Morbidity Management and Disability Prevention. This was new because the entire community claimed a few years ago this area was actually neglected. So this was translated to specific policies, but our formative evaluation at the start of the project found that there's actually no MMDP service in practice. So the program is barely funded beyond MDA, and there is a low awareness at all levels affecting MMDP demand, but also supply. But the demand actually, supply depends on demand. So at the end of the day, demand was an issue and the health outcomes. And since the supply was quite low quality, there was a generalized lack of trust in the already weak health systems. So the main finding of this formative evaluation was that in order to activate the domain around the morbidity management and disability prevention, addressing the right side of the continuum of care, in order to activate this component and in order to sustain that over the long term, it mainly depends on demand. The whole thing basically depends on how well we activate demand and patient mobilization at the community level. Next slide. So here is where we hypothesized on the potential impact of well-established self-support groups in improving health outcomes and mental health issues. Because self-support groups are a well-known platform, well-established in several countries. I particularly know several settings where they implement, both in Africa and Asia, but there is little evidence on their impact, particularly because there's no heterogeneous, there's no homogeneous and standardized implementation. Most of self-support groups try to strengthen the health systems bottom up, since there's no self-care or training at the primary healthcare level. The idea is to train on the home-based self-care practices and community self-care, so they practice on their own and they prevent disabilities longer. So, but the concept about self-support groups is about caring for the self at all levels beyond impairments, and have the potential of integrating several NTDs, particularly those with long-term chronicities. It can also integrate most POD, prevention of disability interventions, and mental health evidence-based activities. So it was a matter of standardizing, defining an essential care packages for self-support groups and implement that model and see what the impact was in improving mental health and health outcomes, of course. Next slide, please. So the primary research question of that study, it was, what is the effect of training health providers, that is the supply side, and most importantly, what is the effect of standardized self-support groups in significantly reducing the burden of disabilities and mental distress. So that was a cohort study among people using recruiting people affected by LF, and distributed in two different arms. One arm A was the control, and in this control there was 4 blocks of one specific district in Bihar, and we trained all health providers at different levels. So this training package was standardized and was mimicked in the intervention arm. So the training component at the PhD level was standardized across arms. The only difference is that in the intervention arm, we also created an enhanced self-support groups and very standardized manner with specific essential care packages. So after a year of follow-up, these are the impact points. I wonder, it's cut this slide at the bottom, but anyway, I'll try to read them out. So in the intervention arm, the people, the cases of hydrocele, this is a subcondition of LF. There was identified 3 times more cases of hydrocele compared to the control arm. And people affected, basically visiting PHC services increased by 4 times in the intervention arm. Patients were 80% less likely to have acute attacks, which is strong fever attacks that blocks or enables patients to do basically their daily course, and you know that condition makes people stay on beds for about 10 days, sometimes less, but these are strong fever episodes, so that was strongly reduced. Health expenditures reduced by 45% in the intervention arm. Most importantly, patients were 2 times less likely to have mild to severe depression through this model. And through qualitative focus group discussions and interviews, we found people that was a common statement, a common quote. Self-support groups, they were perceived as a key platform for mental health counseling. They could share their problems. And that addressing mental health is actually recognizing one of the key priorities for people affected. It was common to see throughout focus group discussions that depression and anxiety is what they were more concerned about. That was the key barrier to manage their condition throughout the continuum of care. So next slide, please. So let me highlight the importance of mobilizing patients or individuals at the community level, and that the evidence suggests that the holistic implementation of quality self-support groups and health staff training may have a strong impact on the long-term needs of people affected by NTDs, including disability and mental health. And trying to mimic the cycle early discussed, we found that the interactions may be wider. And this is not really a linear trend of effects, but it all contributes together. So the better health, the less health expenditures, of course, but the improved mental health outcomes. And all the way around, the better mental health, the better adherence or the better self-care practice, and therefore better prognosis in the long term. And the final slide, please. So here are some recommendations for possible scale-up. The idea, the findings of this project basically suggest further exploration to integrate several NTDs within holistic self-support group models, assess scalability for combined NTD self-support groups and training models, such as the UMIT model just commented. It is also to explore the effects of additional mental health interventions in the self-support group context. What other activities can be merged with a self-support group model and assess impact? So if you have $1 million, how can we better allocate that money so we have more effective interventions? And finally, the idea is also to combine innovative and integrated NTD case detection strategies linked to the self-support group model. We know baselines are overall unreliable. Reported cases are rarely accurate, and active case funding in high endemic countries may benefit for combined strategies for early detection. And strengthening, of course, coordination across health and non-health sectors and partner organizations. We know about the importance of going beyond health. How can we, early discussion, other presentation about One Health, there's so many sectors moving beyond health that can be included and maximize efficiency. Okay, so that's my presentation. Thank you very much. I'll be happy to answer questions later on.
Thank you very much, Guillermo, and thank you for highlighting this very important topic of NTDs and in its relationship to disability and mental health, and how we need to look beyond the health sector into non-health sectors as well, if we are to address NTDs holistically. We now go into our Q&A section, which will be in breakout rooms, and my colleague Afsa will set up these breakout rooms. You will automatically be invited to them. And if we have the time, we may also be able to see this amazing graphic that Tanya is doing, and we might be able to comment on them as well after we finish some of the Q&A. Thank you.
So welcome back, everyone. I hope that you had an opportunity to discuss together, maybe ask some questions. Maybe you had a chance to look at the drawing. In our group, we didn't. We had a great discussion, and we will provide a link for the drawing after the meeting as well. So there'll be opportunities to comment on this. For our next segment, I'm going to hand over to Tina, who is going to announce our new Canadian Network Student and Young Professional Ambassador, and also to thank our current ambassador, Katrina. So Tina, I'll hand over to you.
Great, thank you so much. So Katrina, I don't know if you just want to give everyone a little wave so they know they have the face. I just wanted to thank you so much for showing up for NTDs and the people affected by them in the way that you do. You've supported our steering committee meetings, you've contributed your creativity, creating awareness among young people and telling stories of those working, learning, and advancing NTDs. It's been wonderful to work with you this year, and we will continue to work together this month as we welcome our new SYP ambassador for NTDs. And this is just a little image of Katrina. She's holding up her NTD finger, just representing the 1 in 5 people who are affected by NTDs globally. And this is some of examples of some of her work this year, just to say thank you so much. This year, the Canadian Network for NTDs ran a video competition to select its new SYP ambassador. We received 11 completed and qualified applicants, many of whom are here at our event. I saw Mayela's here, Iris, Samia, Maria, Victoria, Tia, Aisha, and I hope I haven't missed anyone. Some drew connections between their own personal stories and their work. And we were thrilled to see so much interest in our work and our network and NTDs. All entries were reviewed and scored by 7 individuals working within the NTD space. However, one video entry really stood out with a compelling NTD story, a call to action, and striking visual elements. We're going to show you this video now.
Let's talk about neglected tropical diseases and global health equity. First of all, let's begin by reviewing what exactly are neglected tropical diseases. Neglected tropical diseases, also called NTDs, are a group of 20 conditions caused by various pathogens found in tropical and subtropical regions. NTDs can cause symptoms that range from mild illness to disability and to death. NTDs thrive in areas lacking adequate water and sanitation and where housing conditions are poor, which increase exposure to vectors and diseases. Access to proper healthcare and treatment is often challenging in these areas. Now, let's explore global health equity. Health equity can be defined as one's ability to achieve their full health potential, regardless of differences in income, education, race, gender, social status, and physical environment. So what does global health equity have to do with NTDs? Globally, 1 billion people are affected by NTDs. Those living in urban slums, remote or rural areas, and areas of conflict are disproportionately affected. Women, children, migrants, and Indigenous people bear the largest burden of disease. They may face lifelong discrimination, stigma, social exclusion, and disability. Adults may be unable to work, driving families into deeper poverty, and children may miss school. How do we achieve global health equity with NTDs? It takes action at a personal, community, and political level. Start by spreading awareness. Talk to your friends, family, teachers, and coworkers about NTDs. Use social media to share news and research articles. Global health equity starts with your voice.
So, who is this person behind the video? We would like to congratulate Mayela Seguin. She is a registered nurse and a global health master's student interested in infectious disease and fascinated by NTDs. We are really looking forward to working with you this year. And at this time, I'll ask Katrina if she has any words to share, any words of wisdom or.
Thank you, Tina. Yeah, I just want to first of all say a big thank you to Tina and Dr. Kunkel from CNNTD for having me this year. And obviously it was such a great opportunity to work with all of you and work with everyone at CNNTD. It's such a passionate group of people. And to Mayela, I'll just say, just a great job on your video, and I know you're going to do kind of a fantastic job in this role. And I'll just say I can tell you're really passionate about NTDs, and I think that really will guide you in this role. So thank you so much.
Thank you. I really look forward to working with everyone. So I'm just starting out with my master's in global health and infectious diseases, and I'm really looking forward to learning about neglected tropical diseases and working with a passionate team. Thank you.
Wonderful. Thank you, Tina, Katrina, and Mayela. Welcome. And we're delighted to have you on board. And Katrina, a huge thanks. You've been a wonderful addition to the network this year. So we hope you'll keep in touch, and we'll certainly see you moving forward as a member of the network. So thank you. And thanks, Tina, for all that you've done to bring this along and to carry out the competition. So we're just in our very last segment of today, and this is really the next steps. So you've heard about NTDs. Hopefully you've learned something new. And now we'd just like to talk about what we can do and what we're planning to do at the Canadian Network to join the global movement and the global efforts. And so we want to share a short video from Toko Elpikpuli, who is the director of Uniting to Combat NTDs, which is the global advocacy group that the Canadian Network is part of. And so we'll share her video, and then I'll just close with a few remarks on next steps for Canada.
Hello, my name is Togo Elpikpuli. I'm the Executive Director of Uniting to Combat Neglected Tropical Diseases. I'm thrilled to be joining this virtual session looking at Canada's global leadership in the fight against neglected tropical diseases. Allow me please to start by thanking our host, the Canadian Network for Neglected Tropical Diseases, for convening this meeting. Thank you for having me. For those that are not so familiar with the work of Uniting to Combat NTDs, we are here to raise the visibility of these diseases of poverty, to mobilize political leadership and will in ending them, and to mobilize the resources that are required to help us get to the 2030 goals. So what are the 2030 goals? The World Health Organization, in support of SDG 3, has set ambitious targets to eradicate 2 diseases, to eliminate at least 1 NTD in 100 countries, amongst other targets. These are targets that require resources, including multi-sectoral approaches, including working with other sectors in WASH in order to make progress on these diseases. It will need partnership, it will need resources in order to reach those goals. So why should you be inspired to act? Well, great progress has already been made in the fight against neglected tropical diseases. 43 countries have eliminated at least 1 NTD. 600 million people no longer require treatment against neglected tropical diseases. Think about the dollars saved. Think about the lives saved. Think about children that are able to go to school, stay in school, and achieve great attainment that will improve their lives. Think about parents that are able to go to work without fear for these diseases. This is what we are trying to achieve for 1.7 billion additional people on the planet. What about progress in other disease areas? Look at sleeping sickness. In 2011, there were just under 7,000 cases of sleeping sickness reported worldwide. Fast forward to 2019, less than 1,000 cases were reported. That's tremendous progress. What about guinea worm disease? During the mid-1980s, there were over 3.5 million cases of guinea worm disease. In 2020, 27 cases of guinea worm disease were reported. That's tremendous progress. That level of progress comes with responsibility. Responsibility to stay committed to the end goals. Responsibility to sustain progress. Particularly, we have seen the disruption caused by COVID-19. Clearly, countries are committed to fighting COVID-19. The challenge is to make sure that we do not lose the gains that have been made in other disease areas, such as in neglected tropical diseases. This is why we are thrilled to be launching a new political commitment, a new political framework, which is called the Kigali Declaration, that we've been working with, led by countries, really looking to mobilize country leadership in the fight against these diseases. This is a new political framework that will replace the London Declaration on NTDs, with countries at the center committing to the achievement of the WHO 2030 goals and the SDG goals. To kickstart and put fire behind the Kigali Declaration, Uniting is thrilled to be launching a campaign called 100% Committed. This campaign will be launched as part of World NTD Day, and it's an opportunity to bring together civil society, countries affected, coming together to end these diseases of poverty, backed by bold financial and political commitments that will really show the world how we are all 100% committed to ending neglected tropical diseases. So we're calling on you today to take a stand, be 100% committed to ending NTDs by backing this campaign, mobilizing your communities, your leaders to join this fight. Canada has a great opportunity to step up, endorse the Kigali Declaration, put behind it resources that will be required. We're confident that Canada can do it, and we know with your support, you will demonstrate exactly how 100% committed you are to ending neglected tropical diseases. Thank you.
Thank you, Toko. And that's a wonderful call and introduction to the campaign that we can expect in January. So as outlined by Toko, the Kigali Declaration represents an opportunity for all stakeholders to commit to the goals that have been outlined in the WHO 2030 NTD roadmap. And we've referred to that a few times today in our conversation. The roadmap is the guide that is bringing together all of these stakeholders towards the global goals. And these are laid out also in the Sustainable Development Goal number 3. So the declaration recognizes that NTD success to date has been made because countries have translated the international targets into national strategies. Continued country leadership and ownership of the NTD roadmap goals is essential in the next phase of the towards 2030, and it is really integral in how the roadmap is designed. As well, we know that success has been defined by the incredible partnerships and collaborations of governments, donors, civil society, private sector, and academia. By working together in coordination and collaboration, we can meet the SDG Goal 3 target to reduce the number of people requiring interventions for NTDs by 90%, as well as the specific WHO roadmap goals to eradicate 2 NTDs and eliminate at least 1 NTD in 100 countries. Next slide, please. So while much has been done already to reduce NTDs, we still have a lot to do to get to that world free of NTDs. Our goal at the Canadian Network for NTDs is to see Canada sign the Kigali Declaration in 2022. And in so doing, we'll recognize existing Canadian commitments and contributions to reduce NTDs, some of which you heard about in today's presentations. It will also show that Canada will support the inclusion of NTDs in its current global health priorities and participate in the global partnership. We also would like to see continued Canadian contribution and leadership and experience towards addressing some of the cross-cutting issues like gender, equity, disability, inclusion, and health systems. Next slide, please. So what can you do? Well, hopefully you've learned something new today. That was one of my hopes for you at the beginning of this meeting. So talk about it. Talk about it with your colleagues, your family, your friends. Share what you've learned about neglected tropical diseases. Read the Kigali Declaration. Inside, you'll find commitments that apply to you. There are commitments specific to national governments, parliamentarians, mayors, and local governments in endemic areas, continental and regional bodies, the WHO and UN, private sector donors, NGOs, youth, and academic and research organizations. So have a look and see where you fall in the Kigali Declaration and how you might contribute in advancing progress to reach a world free of NTDs. Sign the Kigali Declaration. It's our goal to get as many Canadian organizations to sign Kigali. So read it and introduce it to your organization and secure their endorsement. And this will show our commitment towards that 100% committed goal. And do your part to help Canada see that this is an issue that matters to Canadians. Write to your MP, speak about NTDs and occasions that you have, and the importance of including them in a wider response to global and public health goals. And finally, next slide, please. Mark your calendar. The first official World NTD Day will be on January 30th of next year. And we will certainly be hosting activities and different things for you to get involved with and to be part of raising awareness here in Canada and also around the world about NTDs and the importance of including them in our global health and development goals. So I hope you'll put a note in your calendar towards that effect. So thanks. You can stop sharing the slides there, LaShawn. So thank you very much for your attention today. And I wonder if we can just give Tanya an opportunity just to show us, if we can show her screen there, show us the three images that she's captured, or excuse me, the two images that she's captured during our meeting today.
Fantastic. Thank you so much, Allison. So this is our beautiful summary graphic that we're building out here with some of our main goals for reduction or elimination of NTDs globally and what we need commitments from in order to achieve those 2030 goals. So that's our end goal there as well. And I'm just going to flip to our wonderful talks and presentations we had on various topics regarding this, starting on the left-hand side, the from pole to pole One Health concept and how that filters into our approach and understanding of NTDs in Canada and how that affects people in North America as well. And then moving into the soil transmitted helminths and how this is predominantly affecting young people and women of reproductive age, and how this outreach piece around deworming really improves health and how we should really be aiming for that as it all is connected, again, echoing that One Health theme that we heard earlier. And finally, we had a session around disability and inclusion and how breaking that cycle of stigma and mental health, really that great evidence for support groups and how this could be scaled to whole person health or other non-health related areas as well. And so that was a really beautiful presentation. And these graphics will be shared with you after the session and for further reflection.
Thank you, Tanya. This is the first time I've ever been in a meeting with the graphic minutes, and I think it's absolutely fantastic. So what we'll do, we're going to put a link to a Jamboard in the chat box. And what we would do is welcome your engagement with these drawings over the next hour or two. Tanya would like feedback, particularly, did she capture what you heard or what you think is important in that particular area. And so she's willing to continue to adapt these based on what we feel we'd like to see there. So please do check in with the Jamboard. The link will be going up. Absa, if you could post that in, that would be great. And we'd welcome your comments on the Jamboard and on those drawings to help Tanya further improve them and align them to our conversations. So with that, I think we'll get ready to close. I can't believe we finished 6 minutes early. I am absolutely stunned. And I want to just thank each of our speakers who have gave us a wonderful overview with a really short remit of time. I really appreciate the efforts that they all put in. I want to thank Senator Ravalia for providing such wonderful remarks to lead us off into our deliberations today, and for his commitment, and Senator Kuchar and Senator Beam as well for their commitment to helping us raise awareness of NTDs in Canada. And a special thanks to Tina Lines, who has managed this invite invitations and the schedules and everything, and really appreciate the efforts that she's done. Manish, for his moderation, and our LaShawn and Absa, who've been on the back end, making sure that all the videos are playing nicely. And a final thanks to Katrina, and a welcome to Maila. We look forward to working with you moving forward. We'll post a Google link as well to a Google form. We'd love to hear your thoughts on today's session. It's the first time we've done an all members and friends of the network event. We'd love to hear your reflections, so we might improve it again next year. And please do check us out on the website, join the network. We would love to have all of you as members if you aren't already. You saw the slideshow, and it's a wonderful collection of individuals that I've had the pleasure of getting to know. So we'd love to see you. Please do join us. Bienvenue à tout le monde. So thanks very much, and wishing you all a wonderful remainder of your day. Thanks so much. And we will keep the Zoom open for another 10 or 15 minutes if people are interested in further networking, but the official part of the session is over. So thanks, everybody.